an updated version. So today's topic is actually one I really kind of enjoy sort of working on, right? A topic that I tend to devote a lot of my time to, and something I enjoy teaching about, learning about, and doing clinically, which is opioid use disorders and pain. And this is really just a primer. We can go into a lot more detail with it, but this is really, I kind of want to present an overview of it. And as I begin, of course, just a disclosure statement, and neither does anyone in our hub team have financial arrangements related to the contents of this activity. So we're going to talk about opioid use disorders and pain. I'm going to focus a little bit, and specifically, we're going to have patients, right? If we treat patients with opioid use disorders, we will have patients who are either on Buprenorphine or Methadone or Naltrexone, and they either experience acute pain or they have co-occurring chronic pain. And really, some of the fundamental principles of managing them differ based upon whether it's acute pain, whether it's chronic pain. And especially when it comes to acute pain care in patients with opioid use disorder, a lot of the best practice recommendations have changed fairly dramatically in the last 5-6 years. So I really kind of want to talk about that, right? Talk about sort of the importance, the utility, how pain management might be impacted by medications for opioid use disorder, and some strategies for pain management. I will begin with prevalence. So this is sort of a number of studies that I compiled, looking at percentage of patients who have opioid use disorder who also have chronic pain, right? And you can see that, in some of the early studies that was done by Rosenblum in 2003, put the number at 37%. But some of the newer studies have really pegged that number higher, including this study by Illings-Zare in 2017, which really put the number at almost 2/3, really saying that over, about 2/3 of patients with opioid use disorder also have co-occurring chronic pain. So this is clearly common, and therefore we need to be paying attention to it. And this is that study from 2017, where they essentially looked at over 5,000 adults, right, who had opioid use disorder. So this was a clinic that treats individuals with opioid use disorder. And they essentially did chart review over about a 10-year period, right? And what they found was that out of these 5,000 adults, it was only about 35% that had no history of pain, right? For about 9%, the opioid use disorder, about 9 or 10% opioid use disorder came first, and they developed chronic pain at some point. For about 15%, they had both opioid use disorder and chronic pain at presentation. But for 40%, which was the highest sort of a group, the biggest group, when they obtained the history, when the patients came in to seek treatment for opioid use disorder, the history revealed that the chronic pain came first, and they developed opioid use disorder somewhere later. So for me, one of the take-home points is that very often, chronic pain is very common in patients with opioid use disorder. And given that 40% number, it also makes me really think that could responsible pain management, and stewardship of opioids in patients with chronic pain could, by doing some of those things, can we actually minimize that number and prevent some of these folks moving on to develop opioid use disorder? Perhaps unsurprisingly in this study, patients who started with chronic pain had higher rates of other mental illnesses, other health conditions, but patients who started with an opioid use disorder just had more severe and more substance use disorders, along with things that can often go with that, including HIV and hepatitis C. So now we're going to go into acute pain management, and then we'll go into chronic pain management. And this is some public domain art done by individuals with chronic pain or with living with the pain experience that I found poignant. So I will begin with a vignette. All identifying details have been changed. AN is a 45-year-old female who just recently had a shoulder surgery. She has a history of opioid use disorder and previously at some point was treated with methadone on 2 separate occasions. However, she stopped treatment and returned to using opioids both times. And right before the surgery, she had been smoking about 0.5 gram of heroin about 2 or 3 times a day. And now, post-surgically, she is maintained on morphine continuous infusion, 4.2 milligrams per hour Plus, she can get 10 milligrams Q4 hours as needed for breakthrough pain. And she last used it 2 hours ago, so she's not due for another dose of it for 2 more hours, but she's requesting more pain medication. When you go and see her, she reports that her pain is 9 out of 10. She's in tears, but her vital signs are stable. And you're told from one of the staff, quote, she's drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict and we don't want to worsen her addiction. So let's start with this case and then delve a little bit into principles of acute pain management in individuals with opioid use disorder. I think it's important to start with beliefs. There's a big disconnect, right? We do know, however, from many studies that in general, not even just in patients with opioid use disorder, but in general, acute pain is frequently undertreated in inpatient settings specifically, where that number has been put at about 60%. And it's been suggested that this undertreatment of acute pain might be even more common in patients with any addictions, any substance use disorders. Though, caveat, I'm not able to find any great data, any great literature reference on that. It has been shown that addiction is often seen by health professionals as being primarily a social ill, right, as opposed to a medical problem. And this study is from 2014. Some of the later studies have actually sort of re-emphasized or underlined this belief. So we still have a long way to go in terms of education, right? And patients with chronic pain, or patients with addictions rather, are often seen as being manipulated. So I think it's important to provide, right, patient-centered care. It has been recommended in literature that we start by accepting the patient's self-reported pain. And again, I'm talking about acute pain here. With chronic pain, the approach is very different. And we actually have an entire echo clinic devoted to the management of patients with and treatment of patients with chronic pain, where we really talk about using opioids never as first line, really maximizing our non-pharmacological modalities, our pharmacological, non-opioid pharmacotherapy, using an interdisciplinary approach. But here we're talking about acute pain, where it's been reported that we start by accepting the patient's self-reported pain. Vital signs can certainly be indicators of pain's intensity, but not very reliably. And pain behaviors may vary widely, and oftentimes there are cultural elements to that as well, right? Consider addiction, right, versus the idea of pseudo-addiction versus physiologic dependence. Physiologic dependence simply means that our patients' bodies are used to a particular substance, right? So if it stops suddenly, they will experience withdrawals. And I think that in particular applies to our patients with opioid use disorder, because they do by definition have physiologic dependence and may wind up needing kind of higher doses of medications to treat that acute pain need. Pseudo-addiction is a rather controversial term, arose in the 80s out of inpatient sort of cancer units. And that's this idea where patients are displaying behaviors that might seem indicative of addiction, but that's because their pain is actually undertreated. And when you raise the dose of the pain medications, a lot of those behaviors will dissipate, and importantly, the functioning will improve. Versus in a case of a true addiction, and I think that's much more relevant in chronic pain patients, simply increasing the dose of opioids is unlikely to take away some of those aberrant behaviors or lead to increased functioning. In fact, in patients with a substance use disorder, simply raising the dose of the opioid is likely to continue to worsen the functioning of the patient. It's also recommended that if required, do not withhold opioid analgesics for people with addictions in cases of acute pain. Not a whole lot of data, but there is really no data showing that acute pain management will worsen addiction, right? However, if the pain is untreated, it can lead to cravings and it can actually increase the risk of relapse. Keep in mind that these patients, as I mentioned, have physiologic dependence, so they have tolerance, so they may require higher doses of opioids. And remember that some of these patients might come in on a baseline dose of methadone or buprenorphine. However, those are their baseline doses that's treating their underlying addiction, but will not address acute pain. And I think, unfortunately, this is a common misperception that we come across. So what if you see a patient in an acute pain management setting, maybe you're working on the inpatient unit, and the patient is on methadone for their opioid use disorder? These are some of the best practices. So you can continue their baseline methadone, after verifying the dose from the home clinic. Every patient on methadone will have a home clinic or an opioid treatment program from which they receive their methadone. And that may not show up in the prescription monitoring program, right? But our patients, because they don't want to withdraw from pain, if they're verbal, if they're able to talk to you, will tell you that, hey, I'm on such and such clinic, this is my dose. Make sure you call the clinic, verify it, say this is an emergency situation, the patient is in an inpatient unit or in the ED, and then the dose may be continued unless there are other contraindications, right? For example, patients having torsade de pointe, right, or significantly prolonged QTC, or if they're in respiratory failure, something along those lines. But in general, you're going to continue the methadone dose. If the dose cannot be verified, say it's the weekend and the methadone clinic is closed, it's safer to break up the self-reported dose in 3 or 4 times a day dosing rather than giving it all at once. And because methadone is a full mu agonist, to address additional acute pain management needs, you may actually add in other short-acting opioids for breakthrough pain, and you can gradually increase the methadone dose. Do not administer buprenorphine in a patient who's maintained on methadone, because the buprenorphine will throw them into withdrawals. If the patients cannot take their oral dose, IV methadone is certainly an option. However, you do have to do significant adjustments to the dosing of the methadone to make sure it's safe. Moving forward, what about the patient comes in and they're on buprenorphine, right? They're maintained on buprenorphine for their opioid use disorder, and now they've developed acute pain. So there's several different strategies, right? Of course, we ideally want to employ all of our non-opioid modalities for pain management, and there are many of them, including epidurals, including nerve blocks, including things like ketamine, right? Sub-anesthetic doses of ketamine, alpha-2 agonists such as Presidex, dexmedetomidine, or clonidine. So you really want to maximize those. Now, to address that acute pain in general, you're going to wind up splitting up the buprenorphine dosing to more frequent. So for example, if someone was usually on 12 milligrams a day, you might change that to 4 milligrams 3 times a day, because analgesia with buprenorphine requires more frequent doses. You may also temporarily increase the dose of buprenorphine, can be a very effective strategy, right? So going from 8 milligrams twice a day to 8 milligrams 3 times a day. You can, much like methadone, also consider IV buprenorphine if that is on your formulary. And believe it or not, and this is one of the things we've learned a lot about in the last 5-6 years, that even if someone is on buprenorphine, you can, if their acute pain management need is great, you can actually augment that buprenorphine using short-acting opioids with high mu receptor binding affinity. And our anesthesia colleagues are wonderful at this, and they're expert at this. And fentanyl, although when used illicitly off the street, is very, very dangerous. In settings like this, fentanyl actually has a pharmacological profile that is very favorable. It is, you can titrate it in very gradual increments, it's short-acting, and can really provide additional analgesia. And if in doubt, consult an addiction medicine expert or an addiction psychiatry expert. What about perioperative? So perioperative, if you have a patient maintained on buprenorphine who's going to have a surgery, important to keep in mind, again, that there is this big gulf where our patients fear mistreatment and providers fear manipulation, right? So if you're the outpatient provider, ethically, it's really important that you're working to bridge that gulf. So the pre-op stuff is very important. I tell all my patients who are on buprenorphine or naltrexone or methadone for that matter, that if you're gonna have a procedure, as soon as you find out what the procedure is, let me know so we can start the process. We get multi-party consents, we start the talk, hey, how are we going to manage this patient's pain to really avoid any problems perioperatively. In general, one of the big shifts in the medical field has been that before, what used to happen is that if someone was maintained on buprenorphine, they were going to have a surgery, the buprenorphine would be stopped about 3 days before the procedure. They would go on full mu agonist, and those would be stopped, and the patient would be restarted on buprenorphine. But really now the consensus has shifted, where we recommend that in general, buprenorphine should not be discontinued for most procedures, for most routine procedures. Some clinicians may lower the dose to 8 or 16 milligrams per day, divide them up during the perioperative period, but in general, you can continue the buprenorphine, right? We don't routinely discontinue buprenorphine. This is another sort of slide stating the same thing, and I really am trying to highlight that, right? That buprenorphine is a powerful analgesic. So we keep that on board, maintain it, and then do other things, right? Essentially multimodal analgesia, those things I mentioned, like ketamine, like blocks, like epidurals if appropriate. Using full mu agonists such as fentanyl or dilaudid if necessary. And this is the editorial from 2018 from Pain Medicine by Anna Lamke that really started to bring about this change in the field from about 3 years ago. And now most experts would recommend this. Naltrexone. Acute pain management is difficult with naltrexone. So I tell all my patients, this is a Verdi slide. I apologize about that. These are the key points, that naltrexone is a full mu blocker. So if I have a patient on naltrexone, I tell them, in fact, I started a patient yesterday on naltrexone, and I told them to carry a card in their wallet that says, hey, I'm on naltrexone. So in case something happens, in case they need acute pain management, first responders can respond appropriately, right? In general, in case of an emergency, multimodal analgesia is going to be the name of the game. However, if it's an elective procedure, if you have a patient on naltrexone, they're going to have an elective procedure. What we recommend is that if they've been getting the injectable long-acting naltrexone, the injection should be 4 weeks before the procedure. If they've been taking the daily oral tablet, the last tablet should be 72 hours before the procedure to achieve adequate analgesia. And so now with that, I'm going to glance at the time. I'm going to go to chronic pain management. Again, we have a whole echo devoted to this, but I do want to hit some major principles of it. And I know we don't have a case, so I'm taking a little bit of creative liberty here and going a little bit slower or a little bit more in detail than I normally might. So this is another piece of art from someone with chronic pain, which I thought was poignant. Basic consideration. So unlike with acute pain, where I say trust the patient, don't be afraid to treat that acute pain if needed, the basic considerations I think are very different when we're talking about non-cancerous or non-terminal chronic pain, right? Because remember that a prior history of opioid use disorders is the single biggest predictor of someone misusing their prescribed opioids or aberrant behaviors to prescribed opioids, right? So in general, again, you want to maximize all of those non-pharmacological approaches, including CBT for pain, acceptance and commitment therapy, right? Physical therapy, acupuncture, traditional healing, chiropractic, right? TENS unit, all of those things. You want to maximize all of your non-opioid medications before turning to opioids. And even if opioids are prescribed, it should be done under very careful management or monitoring and very close monitoring. And we actually have a whole other talk we do as part of this echo on monitoring of opioids in patients with chronic pain and opioid use disorder, right? And you want to use multiple, right? So responsible opioid prescribing in this group means being aware of individual risk factors, using validated screening tools, such as the SOAP-R is the one we use here at UNM. Which has been validated in primary care as well as chronic pain populations. Monitoring, ongoing monitoring for any aberrant behaviors, right? Is the patient running out of medications early, for example? Making sure we're checking urine drug screens, PDMP monitoring, treatment agreements, and of course, ensuring naloxone co-prescribing, which can save lives. So now, a little vignette on methadone and then buprenorphine. So this is a vignette on methadone and chronic pain. This is a 64-year-old female who presented to the emergency department with dysuria. And at presentation, she was found to have advanced cervical carcinoma with local metastasis. And the need for pain management was identified. There was, however, concern about her 30-year history of heroin addiction and concerns about injection drug use, right, centrally. If she was discharged with a port, for example. So at that point, we communicated very closely with the oncologist, with the palliative care docs. We started her. It was decided that the patient's pain management need was going to be so great that buprenorphine simply would not cut it. And no one was comfortable prescribing her tons and tons of opioids, right? So we actually, at our opioid treatment program at the University of New Mexico, started her on methadone and carefully titrated it up. Meanwhile, her palliative care docs placed her on short-acting opioids for breakthrough pain. And we collaborated very, very closely. And ultimately, the patient did very well for the other 3 years that she was alive, never really had a relapse, remained in treatment, and really felt grateful for the care that she had received. So methadone in chronic pain, in patients who have chronic pain and opioids, buprenorphine is usually going to be your go-to. But in some cases, the opioid dependence may be better treated with methadone, right? If the pain management need is going to be so great that you think that effective analgesia simply cannot be achieved with buprenorphine. But for most patients who have opioid use disorder and chronic pain, buprenorphine, I think, is the ideal medication. And that's the case I want to make in the remaining few slides. So this is another vignette. 55-year-old female patient presented for addictions treatment. She had a 12-year history of chronic pain following an ATV accident and a pelvic fracture. And over time, she had gradually increased her doses of opioids all the way up to 300 morphine milligram equivalents per day. And remember that we said that if someone's on, certainly higher than 100 morphine milligram equivalents a day, the rate of a number of adverse events, including overdoses, is significantly elevated. And she had built up to over 300. And they were aberrant behavior. She was buying them off the street. She would run out early. She would turn to multiple providers, and she was having problems. It wasn't helping anything, right? Addiction was there. Her functioning was worsening. She was having problems in her marriage, at work, in relationships. She was reporting worsening depression and anxiety. And she actually said, I have pain all over, and it's worse than ever. And we thought that she had developed opioid-induced hyperalgesia from chronic opioid use. So after talking to her to address both the chronic pain and her opioid use disorder, we essentially stopped all of the opioids she was taking and put her on buprenorphine / naloxone, so the combination medicine, 4 milligrams 3 times a day. And she actually did well on it. She reported improvement in pain. She said she was happier, she was functioning better at work, and said, quote, I have my life back, right? So don't forget about buprenorphine. That it is a good option, where, consider and talk to your patients that if they're on buprenorphine and have chronic pain, it's going to be hard to get analgesia from other full mu agonists. So you're not going to wind up adding those on. But in many of these patients, a big subset, I would say, buprenorphine may actually target both, where you're going to wind up splitting the dose of buprenorphine to help with the analgesia. And there is suggestion in the literature that buprenorphine can help mitigate opioid-induced hyperalgesia. It's just a reference slide that lists many reasons why buprenorphine may be a good option as a frontline analgesic. And this is a study, it's about 5 years old now, 5 or 6 years old, from California, where what they did was they took patients with chronic pain who were maintained on very, very high doses of opioids, often multiple opioids, and they were at risk for things like overdoses, converted them over to buprenorphine monotherapy, and basically looked at what happened to their pain. And you can see that in this study, for all these patients, even the ones who were at very, very high doses of morphine doses, over 1,000, their pain experience improved significantly. Here, the higher the number, the worse the pain. It's just the visual analog scale from 1 to 10. So you can see clinically and statistical improvement in pain 3 months after they were switched over to buprenorphine monotherapy. And certainly they were a whole lot safer being on just buprenorphine than all of those other opioids. So don't forget about that. Think about that. Keep in mind that sublingual forms are approved for treatment of chronic pain. They're not approved for treatment of chronic pain, but can actually be very effective and are commonly used. We do have the buprenorphine patch that's approved for treatment of chronic pain, along with this buccal formulation, but they tend to be lower doses. So at least in the United States, so many providers, many pain management docs will wind up turning to the sublingual buprenorphine to treat pain. And finally, naltrexone, just one slide, that if someone has great chronic pain, need for chronic opioids, naltrexone may not be the best medication, right? And we really should be thinking about usually buprenorphine and maybe methadone in some of those very severe cases. And I will end here.